Wonderful, thank you. It's great to be here. I want to just take a moment to sort of introduce the topic, which is really the arc of clinical AI, and to talk a little bit about sort of where we are and maybe where we're going with the development of clinical AI. But I first want to start with a deep note of thanks to Dr. Chinnababu, the leaders of the conference, Yashoda Hospital, for really incredible, actually beginning on Friday with the T-Hub event, but yesterday, so many ideas, so many thoughtful speakers, and I'm very, very grateful to be able to share a few thoughts with this group today. I think by way of introduction, it's probably useful to share a little of my background. I'm basically an ICU doctor. That's essentially the only job I was ever fully trained to do, and it's a job I spent a lot of time doing. I finished medical school in 1996, which is now referred to as the late 20th century, so 30 years ago, and I spent about 25 years in Boston in the practice of adult critical care. This is me in May of 2020, so it's a time that many folks will remember. And I'd say it was foundational to my understanding of both the strengths and the limitations of where we are as a system globally in terms of healthcare delivery. So one lens is very clinical. The other lens is as an educator, and I spent a lot of time, both early in my career and throughout my career, teaching medical students, residents, fellows. I ran both an ICU and a fellowship training program and ended up as a chair of Department of Medical Education and associate dean. And I'm what I would call a techno-pragmatist. And by that I mean, I'm not someone who believes AI solves everything. I'm not someone who believes that if we just turn it on, it'll run perfectly. But I've had experiences in my life that give me real hope that we are at a inflection point where the use of technology can really change the trajectory of human health and make billions of people healthier. Early in my career, I took a job that pretty much everyone told me was a bad idea. I was finishing my fellowship training program at a very prestigious hospital in Boston. I had an opportunity to stay on as a junior faculty member, and then I was presented with another opportunity to spend 80% of my time working inside in front of a computer at a company that was very, very new called UpToDate that was sort of reformatting information for clinical use. And I took that job and I spent about 5 years at UpToDate when it was a small company, and I learned an enormous amount about the intersection of information presentation and decision making, and I think that was a foundational event. And then I started working while I was still very clinical with Yossi's teams and the Google research teams on medical records research, and so I gained a little bit of insight nights and weekends sort of over the course of several years before joining Google and the Google for Health team in 2020, the end of 2020. By way of, again, introduction to Google is a very large company, and we have obviously lots of different surfaces, including surfaces that have billions of monthly users. And the health team is really designed as a horizontal team of clinicians like me, regulators, researchers, who are focused on health across the company. So we work as a central horizontal team that provides clinical support to all of Google, including search, YouTube, Fitbit. My team is particularly focused on one thing, which is how do you take research ideas and scale them for enterprise healthcare and life science partners globally. And so my team is really focused on scaling innovation. We have 4 major focus areas at Google on the health team. I'm going to focus mainly on the first, which is sort of where does the cutting edge and the future direction of care, what are we seeing there? But a lot of what Google does is meeting people in their everyday lives globally to provide information. Actually, an enormous amount of the information we provide is health related, and we really think of information as a social determinant of health that helps people on their informational journeys to get better health, whatever that means for them. I mentioned a little bit about the work that we do transforming organizations working in health, and we also focus on a thriving health ecosystem. We do that through partnerships with WHO, the National Academy of Medicine, and other teams and people who are thinking about the implication of these new tools on care as it's delivered. I want to actually pause briefly to not talk about AI, but just talk about human decision making. And human decision making around medical information or other kinds of information is actually quite similar. And this is the image that I showed under the educator slide. Some people might recognize System 1 and System 2 as the fast and slow thinking systems of Daniel Kahneman, where we have some thought processes that are very intuitive and run in series and are almost effortless, and some things that we have to think about deeply and in series and over time. And one way to think about medical education is that it is a process of helping people understand illness presentations by recognizing patterns. And humans are really good at recognizing patterns. And then over time and with training, things that are initially effortful become less effortful. You recognize the pattern sooner. And so a lot of what we do in medical education is essentially training our pattern processors to deal with data and sort it into recognized versus unrecognized groups. Now, one of the challenges to that is that the amount of information that you have to process to generate that illness representation has gone up a lot. So this is the last 20 years with the representation of medical record data, including text, lab, genomic, imaging, and increasingly wearable data. This looks like a pretty steep linear increase, but there's a mathematical trick. The vertical axis is a log axis. So a straight line on a log axis is an exponential rise. And this graph actually probably underestimates the amount of data that we have to process, right? Our human processors have to deal with. And so we are, all of us, in a situation of too much data and not enough information. And so I sort of think of AI as a bunch of different tools, not all of which are brand new, that we've actually used in medicine over decades, but that now have hit an inflection point with transformers and new technologies. So we used intelligent systems for things like figuring out complex acid-base problems even back as early as the 60s and 70s. I'll give examples of machine learning tools, many of which have already been referenced over the last 2 days, that sort of represent AI or machine learning that's already got a footprint in clinical practice. And then what we'll sort of turn to is the transformer revolution and how generative models with much more rich outputs are sort of changing the way we think of how and what is possible. So a number of tools that have been mentioned that leverage AI are already being used at the point of care, and Google's been deeply involved in the research of these, including work on mammography with Northwestern, diabetic retinopathy, which is now 10 years old, and we've talked about here in a number of different ways, tuberculosis, including partnerships here in India to develop smart learning systems going back almost a decade, and radiotherapy, which was mentioned earlier, segmenting the sort of very careful manual work that radiation oncologists needed to do historically to map radiation ports and fields, which could take, I think we heard 5 hours, sometimes longer, has been compressed with ML algorithms that we developed with Mayo Clinic and others. So what's different now? I think there are two trajectories, and I want to focus on both of them that are converging and that are really driving the evolution of clinical AI, what we think is possible. And so I'll talk about these in turn, but I think it's important to understand that part of what's changing relates to the development of the AI technology, and part of it relates to the evolution of concepts around health, healthcare, and healthcare delivery. So I'll go through these in turn, but I think one of the things that is very clear is that AI is as bad as it'll ever be right now today. We will look back at this as sort of the dial-up AOL days of AI. And one of the things that we're seeing is that AI models are improving. That improvement isn't always linear across all fields, and some areas that you might have thought progress would be relatively slow, we've seen incredibly fast progress. So Math Olympiad, sort of competitive math, PhD level science, materials science, these are places where we've seen very rapid acceleration in model performance. At the same time, the cost to run these models is dropping logarithmically. So I think there's reasons to be enthusiastic about the core capabilities continuing to develop. One of the other things that I think is really interesting to look at is time and space are becoming first-class variables. What do I mean by that? Historically, we've used lots of different modalities stitched together, text, image, language. Now we're using what are called world models, and what you're seeing on the screen is Genie 3, one of the latest world models from Google that is promptable. You can create a prompt, you're in a helicopter, but you also have a joystick. You can move through a world, and it's a world that has memory. If you touch one thing in a place, you'll come back to it and you'll see it's still there. Or if you walk through a door and turn around, the image that you see should reflect where you came from. And so these tools, which are really helping us understand time and space comprehensively, have lots of implications on simulation, particularly in high-risk environments. What you're seeing right now is an example, again, of that memory where someone paints on a wall, interacts with this world, turns away, and then turns back to see that the interaction persists. These are promptable, so you could say, I don't know, have a guy with a jet ski come flying by on this nice little walk, or a guy in a chicken suit. And so you can see sort of opportunities for these physical, understanding of the physical world in very, very different ways. That's important because it really serves as the jumping off point to embodied AI and tools that can understand their environment holistically. So these robots are using essentially world models and vision to navigate an environment that's very dynamic and changing. I think one of the other things that's been mentioned, but I want to lean in a little bit, is that we're seeing new interaction patterns. We're not just seeing back and forth chatbot experiences between one person and one agent, but rather we're seeing teams of agents, sometimes working in series, sometimes working in parallel to, as an example, generate scientific hypotheses. On the left-hand side, I sort of like this. I don't know whether anyone's had a run-in with reviewer number 2 in your life, but you can sort of think of these tools as being able to create personas, and maybe you want to create a persona that's a really tough reviewer who will look at your manuscript or your research proposal and provide substantive feedback. I think the other shift that we're seeing is that patients are using AI at a very rapid pace around health. Patients are very willing to enter the most private details of their lives into publicly accessible endpoints because there's value there in terms of understanding their health and their health journey. So I think we're really going to a world where the relationship will be more triadic. And by that I mean a patient might have a health coach that knows all of their personal medical details and can provide feedback on day-to-day things and then help them know when to escalate. Or similarly, a provider may have a co-clinician who provides insights, help with prioritization, help with mundane tasks to keep the provider operating at the very top of license. The idea that we're moving away from point solutions and software as a service to a much more integrated data environment where the data layer and the inference layer and then the API layer sort of sit locally in a highly secure and highly composable environment. And this idea that that middle intelligence layer continues to improve over time. Shifting a little bit away from sort of the rise of technology towards the evolution of health and biology, DeepMind and Google Research have made discoveries that solve certain what are called root node problems in biology. So how do you go from a linear sequence of amino acids to understanding a three-dimensional protein structure. That's a root node problem. If you can solve that across all cases, you can go from a world where it takes about 5 years to take an amino acid sequence and figure out exactly what the protein structure, to a system that essentially solved for all 200 million known amino acid sequences essentially over a Christmas break and then published those results. AlphaGenome did not win the Nobel Prize. AlphaEvolve did not win the Nobel Prize. It's a little confusing from this image, although AlphaFold did. And AlphaGenome, again, is a new tool to help understand the parts of the genome that don't code for proteins. About 90% of your genetic code is actually not involved with protein coding. It has profound impact on health and disease. So understanding those interactions at a foundational level is critical. One of the other big shifts that we're seeing is a foundational change in patient-reported outcomes to continuous patient measures. You know, historically, we've used retrospective, delayed, sort of episodic and low dimensionality data to understand patient state. Now we have tools that allow measurement of heart rate variability, sleep, exercise, skin conductance to provide real-time and continuous patient data, patient state signaling. And we've developed tools, AI models, that are able to navigate over all of that complex health information to provide recommendations. In the US, sentiment around prescribing authority is changing. That has very important impacts in terms of what the role of the doctor is. In 2005, there was a movement to make HMG-CoA reductase inhibitors, statins, available over the counter in the US. The medical profession and the judicial system decided that was not acceptable, and so you can't get statins over the counter. But in 2025, changes in Texas mean that you can prescribe yourself certain antibiotics. And in 2026, very interestingly, Doctronic announced plans for AI-driven prescription renewals. And again, this is a change in how we've historically thought about prescribing authority. With all that said, what I really want to do is now, in the next 15 minutes or so, talk about the evolution of clinical AI and sort of how we've approached that inside of Google and where we are in that process of sort of thinking about how much AI would be able to take over or to serve as a co-clinician. And so I'm going to walk through a little bit of how we've thought about that. But essentially, the approach was to take the AI to medical school and essentially sort of think about the sequence of steps where an AI would need to show proficiency before it could move to the next level. We started with multiple choice questions and developed systems that could pass boards exams at a sort of higher at a sort of outstanding human level. We moved on to sort of what we call simulated consultations. People may be familiar with the New England Journal CPCs or case reports. These are usually 2 or 3 pages long, multimodal, with images and lots of data, and sort of seeing how can an AI perform on this more generative task of solving a very difficult clinical problem. We then moved to simulated consultations, text-based back and forth, essentially an OSCE exam for an AI to see if an AI could perform at the level of a human in terms of evaluating and assessing a new patient. And then, having sort of established that we could do all of those things, we started to move into human studies. And it's very important to understand the framework of what we're asking the AI to do in these studies. But basically, we're saying we're letting the AI work at the level of a senior medical student. They can meet the patient, they can talk to the patient, they can do a full interview, they can generate a plan of care, but they don't give any of that information back to the patient until a human has assessed the performance and says, yes, maybe there's some slight alterations, this is the plan that we can take forward. So we've been working with that, and what we've seen in this hill climbing effort, and these have all been published over the last year and a half, we've been able to kind of make that hill climbing to conversational diagnostic AI, text-based back and forth to do a pre-interval, a pre-visit intake. So this is the results of that prospective clinical feasibility trial. This was 100 patients at Beth Israel single center in Boston. And a couple of things are important. One is that there were no safety stops, meaning we were watching real time, and if there was anything in the AI-human interaction that looked like it may be taking things off course, there was a system in place for intervention. That system was never used. We assessed patients' trust of AI before they talked to the AI or interacted with the AI, after they interacted with the AI, and after they interacted with the provider who kind of gave them the bottom line answer. And what we saw was a rise that was sustained in terms of patients' trust in AI. In other words, you working with the system increased rather than decreased trust. The differential diagnosis generated by the AI matched more or less where a human would land. And if you asked a human to rate the human plan versus the AI plan, it was about 50-50 in terms of preference. And so with this work, we're now moving from a single center to a multi-center study of this text-based back and forth intake as a system to multiplex the time of the provider, so that rather than walking into a exam room and seeing just a chief complaint, you would actually have a draft of the HPI, you'd have a draft of the assessment and plan and patient communication. So we're continuing to work in that direction. I think getting back to that idea of a triadic relationship, what we see is that those studies have important interactions with the kinds of insights that people will get from automated health coaching. And so we think of the tools like the co-clinician as the clinician-facing side of that triadic relationship, and personal health coaching that is sort of on-device and highly secure and highly personalized as the person-facing health coach tool that serves as a correlate. The other piece of this puzzle is sort of how do these various personas, mainly the patient, interact with their environment, and particularly how do they navigate their clinical course and find the right care, the right information. All of what I presented really was state-of-the-art up until just a few weeks ago. And so I want to kind of give insight into one thing that's really new and different. Everything I've talked about in terms of the clinician has been text-based back and forth. And I think we would all agree that that doesn't necessarily play to our strengths as humans, and it doesn't really match the real-world challenge that we all face of taking in all of the things, what the patient looks like, what the patient says. And so what we're moving to, and the most recent publication, which we call Towards Conversational Medical AI with Eyes, Ears, and a Voice. I didn't know the title of the previous talk, but it fits. Rather than taking text inputs, this takes real-time audio-visual input. So it takes everything seen on the video screen and everything said by the patient. That goes into a two-compartment model. One part of the model is the talker that essentially handles the primary patient interaction, handles communication, interprets immediate audio-visual cues, and sort of keeps the conversation going. There's a second agent, the clinical planner, that has sort of the clinical insights and is essentially looking for discrepancies between what's said and what is seen. The patient says they have a weeping rash, but the AV feed does not look like there's a weeping rash. So the AI says, hold your arm up to the camera. Let me get a better look at that. Or helps to guide a clinical assessment. So we've externalized this, and again, I think it's worth a look. You can follow the QR code, but I thought I'd play just a brief snippet. This requires a little bit of a setup. What you're going to see on the far side of the screen is a simulated patient. It's actually a doctor pretending to have a condition that results in a unilateral eyelid droop. I won't ask any of the medical students in the back for your entire differential of unilateral eyelid droop, but let's just say it's long and some of the things on there are bad. So what we're seeing is a doctor pretending to have a condition interacting with this AV system, and then you'll see both the doctor and another clinician who's involved in the study talking and reflecting a little bit. And I'm just going to play a minute or two here.
But I do notice sometimes I see double.
Does the double vision happen more often at certain times of the day, like when you're tired?
Yeah, I notice that when I first wake up, it's not too bad, and then after about an hour or two, going about my day, my eyelid droops a little bit more, and I see more double.
There's a very similar condition called Lambert-Eaton myasthenia, which gets better as the day goes on. So it's immediately asking one of the most important relevant questions that a neurologist would know to ask. So here we can see in the thought log that it says, the fatigable nature of ptosis and diplopia, diplopia is double vision and ptosis is the eyelid droop, strongly suggests conditions affecting neuromuscular junctions, prominently myasthenia gravis, which is a spot-on assessment.
So I think and I would encourage people to look at the series of 3 videos that we posted in association with this work, but I think it's very, very interesting to really think about what multimodality means and what multimodality brings to these kinds of studies. Some of the findings I think are super interesting, and I'm going to highlight a few. One is that we used that clinical planner. You can sort of think of that as the brains of the operation that sits underneath the talker, and just made that available to clinicians for certain kinds of medical QA. And we found strong preference for just using the planner module separate from the AV feed when compared to more generally available tools. The other thing that we did was we looked across a whole range of areas in terms of how does the AI perform relative to humans. And I think I want to really point out a couple of things. One is that for triage and history taking, right, the stuff that you might say a medical student could get through, these tools are showing real promise of getting close to human performance. And in clinical reasoning, there is some overlap. One of the things that I think is most interesting, if you look at this literature, it shows up again and again with text-based interactions. Humans do worse than AI for empathy. And it shows up as what's called an empathy gap with humans dealing, when you compare a human to an AI for text-based interactions. And it's been true in our studies, it's been true in other studies. I think that's an epiphenomenon of not taking advantage of what humans are really, really good at. And so one of the things that I was happiest to see is the finding around communication and counseling, where go humans, right? The humans are still better than the AI in some things that relate to, I think, that relational connection that is so important. And so I think, for me, this publication is interesting on a number of levels. I think that the AV continuous real-time is probably the thing that gets most immediate attention, but I also think it's starting to point out some of the ways in which these systems still need a human to deliver care. I'm going to wrap up with just what I call 6 ideas for a complicated world, and I would certainly welcome thoughts on all of this. The first is that we are living through an epistemic shift. We're living through a time when our relationship with information is fundamentally changing. This has happened before. We had the germ theory of disease, right? That was an epistemic shift. That fundamentally changed the way we thought about information and the world. And so I think it's not hyperbolic to consider the implications for medicine, the implications for education as truly epistemic. The other thing is that, as I mentioned, we're in early days. And there's this quote from a sociologist named John Culkin that really sticks with me, which is, we shape our tools and thereafter our tools shape us. And I think all of us are in a very important tool shaping moment, right? The clay is still very, very soft. And the power of these tools is undeniable, but I think it's very, very important that we are clear on what it is we seek to do. And that's really the next point, which is, Many talks about AI have what I consider a cart-horse problem. We get very enamored of the technology, and we don't talk as much about the practical application. And I think it often is manifest in what I call a cart-horse problem. You have incredible AI, so you go out and look for a use case. It's much more effective to look at your practice. What is the most broken, painful, informational transformation or workflow that you have? Ask yourself, could AI help with that? I think if you work backwards from those problems and think about AI as a giant toolbox that's getting big very, very fast, it's much easier to be concrete about the goal to be achieved. And that also should be associated with metrics, process metrics, outcome metrics, so that you know what good looks like. The other is that work transforms in three ways, and we've talked around this, but one is automation. You replace the human, you take the human out of the loop, and you accelerate the process. The second is augmentation, where you elevate the human to those most critical points in a workflow. And again, the goal is to take a current workflow as it exists and accelerate it and move the human to the highest value in terms of their decision making. Innovation is different, and I think here of a quote from Henry Ford, who said if he asked people what they wanted, they would have said faster horses. And I think that that's the other way to think about these tools is yes, they are very useful in accelerating work as you currently imagine it, and they are incredibly useful if you have the opportunity to reimagine a workflow. Those are different, right? And how you approach system change for innovation versus augmentation or acceleration is also probably really different. I think it's always important to start with low-risk use cases. I think it's one of the other challenges that we suffer from is too much theory and not enough practice. I think starting with simple use cases, I'll tell you the first agent I built. It's so dumb, and I love it. It's a sommelier. I don't drink wine. I don't know anything about wine. My wife drinks about 1 glass of wine a month, and it's a big deal because there's a lot of, shall we say, constraints. And so I built a sommelier so I can just take a picture of the wine list at any restaurant I go into, and it sends her recommendations right to her phone. It's really dumb, but it solves a problem in my own personal life. So I'd say, like, practice. And then the last piece, I think it's really important, and this is one of the reasons why I was glad to talk about the education piece, is that all of these tools, I think, will force us to need to redefine somewhat what we mean by expertise and what it is that we seek to teach and elevate in the people who take care of other people. I want to thank this group on a number of levels.
Thank you.